Good morning. It's a true pleasure today because I think today is one of those days where the whole organization can shine a little bit because we're going to almost release, not there yet, but almost release 4 of our trainees to the world. And one of them actually stays here. So always a good moment. I think also special today is that one of them is in some sort of fancy airport lounge, probably presenting virtually because he can make it. And that would be Dr. Salih. Before I start, we want to thank Edwards Life Sciences and Janssen Pulmonary Hypertension for doing the exhibit today. So if you have a chance, just maybe say hi to them. Good. I think 2 talks are about coronary disease. So just to give a little overview, we have 2 interventional fellows, 1 structural heart disease fellow every year, and then also a vascular fellow, obviously. And the 2 interventional fellows are going to present, I think, topics around ST segment elevation. And the first one is Dr. Salih. He came from Springfield, did his fellowship here, as everybody in this group really excelled, and now becomes, I read, an assistant professor in the institution that he just came from. So that's always good to see too, that you get a job right after fellowship, and then if the institution takes you back, I think that's also a very, very nice sign. So he's going to talk about revascularization strategy for STEMI with multivessel coronary artery disease. And what I heard is what we're going to do is 10 minutes of a talk, and then everybody has 5 minutes of questions, and then we go on to the next talk. So Mo, are you ready?
Yes. Thank you, Dr. Gazel. And I could not be with you last night. I have flight issues, so we'll start. So I'm going to present today revascularization strategy presented with STEMI, and they find they have multivessel coronary artery disease. So disclosure, and my objective is to talk about the background for coronary artery disease and STEMI patient, and then we'll go through the strategy for those patients, and I will go on overview of the and the guideline. So it's 10 minutes, so I try on time. So the patient presented with a STEMI, and when we do the coronary angiogram, about 40–50% of those we find they have significant lesion in non-carpet, and it's very important to discuss this topic because the coronary artery disease associated with higher mortality rate and rate of reinfarction, and the higher mortality rate could be related to multiple factors that we see during the angiogram, but unfortunately have the excellent tool to figure out which plaque is vulnerable. Till use imaging and maybe using the IFR to see how significant those lesions, but we don't have they tell us is the plaque vulnerable or not. So back decades, Goldstein and his colleague did this, where they looked into about a 250 patient presented with, and they reviewed the angiogram, and they find about 40% of they have multivessel coronary artery disease, and they followed those patients, and they comparing the patient who had multiple plaque to single plaque, and they the multiple plaque, which is the plaque column here, it's associated with rate of repeated cardiac revascularization single plaque, also the recurrent of ACS or the syndrome, plus the rate of the vascularization either per or by cabbage is higher in those patients with multiple plaque comparing to single plaque patient. What's the strategy that we have to treat who presented with STEMI and multivessel coronary artery disease? So a couple of strategy, but three main strategy or three broad. First one, we just treat the culprit vessel intervention, and we just treat that culprit and we're done. If we treat only, then if only treat those multiple multivessel stable, we consider stable if a patient presented later with or if he has high risk of non-invasive testing. The second step is we treat the culprit vessel, then we stage the lesion. Either we stage them during the same hospitalization later in few weeks after discharge. The third strategy, which is basically the complete revascularization during procedure. That means when the patient presented with STEMI and we treat everything. What we have for the supportive evidence or the evidence base. So it was evolving very quickly in the last decades. Actually, we had conflicting data because what we had in the beginning, observational study and meta-analysis. And those studies, they have large heterogeneity, including the inclusion criteria endpoint are different in those studies. The sample size are small. The time, some of them they done during the index procedure, and some in the index hospitalization, and some are stage 6. And also selection bias because they treat only the sick. So in 2013, depends on the data at the time, the STEMI guidelines saying it is harm to the patient with STEMI presented with STEMI and they have multivessel coronary artery disease when they are hemodynamic. So it's 3B and it's harm. And 1C only if the patient presented with, but they have spontaneous symptom of ischemia and later. And 2B level when it's reasonable and treat them if they presented with STEMI and they have intermediate or high and non-invasive testing. So this guideline like that because all the data that we had at that time, it's showing that there long procedure time, more complication, more contrast, and that's a contrast induced nephropathy and stent thrombosis. And risk of bleeding is higher when you treat everything. So the trial came is the BRAMI trial comparing culprit only BCI for the culprit lesion patient presented with STEMI, and the other arm where they do everything. So they treat the complete revascularization, and the primary endpoint for the cardiovascular death, MI, and refractory angina, and the result is showing that 9% the rate of the MAZE, it was 9% in the which is complete revascularization versus 23%, which is a huge difference with risk reduction 65% and absolute risk reduction was 14. And the Kaplan-Meier here showing how much conversion between Then the second randomized trial came is complete revascularization, about 300 patient randomized arm to answer the question if we stage those patients, because the BRAMI trial was an index procedure. Here we're trying to see if we do it staging index hospitalization, and the primary endpoint is the MACE, including mortality, recurrent MI, heart failure, ischemic driven revascularization. And it's the same here. It's showing that about 53% in the MACE, with 10% versus 21% in the only. And this is mainly driven by a rate of revascularization, and there the concern between the two groups. And here's the Kaplan-Meier scene. The MACE is more or less in revascularization. As I said, it's more driven by revascularization. So then the next question was which culprit lesion we should treat. Are we need to depends on the angiography? Are we need to look which vulnerable plaque depends on the angio, irregularity, ulceration, haziness, or we should treat the simple lesion, the complex lesion? Do we should just that the intervention will be safe and feasible, treat that lesion? If not, then just leave it. Do we have coronary physiology? And because of all those questions that came after the last two study, then the trial, it came to answer the question, is there a rule for physiology? This is control trial. We're comparing the complete revision using FFR guided versus BCI culprit only. So the primary endpoint is a MACE, where it's a all-cause mortality, recurrent MI driven revascularization, and the study showing that's 44% composite endpoint, where it had the primary endpoint happened in 13% complete revascularization guided by FFR, 2% in the culprit only. And it the FFR guided multivessel reduced the number of revascularization. And Kaplan-Meier, you see the primary endpoint for the complete revascularization guided by FFR is much lower. So the trial, the STEMI guideline 2015 update, and it changed from 3 to 2, reasonable to do it when the patient is hemodynamically stable, and there was no clear guideline whether to do it at index procedure or staged, and keep it open for us. Then they came in, is the FFR in acute MI accurate? Because there was concern on those patients, there will be a microspasm, and we see those patients when we do angio, for, the vessel looks very small and spasm, and the FFR maybe will not be accurate because the is limited, and that's partially because the spasm also by the microthrombi that's go through the microvascular, also the edema that increase the flow. So after that, the acute it came in to answer this question to see if the BCI for non-culprit artery comparing to the or the group that has treated for culprit only, but the FFR non-culprit lesion, the FFR will be similar in those patients or not. So it was to reduce the primary composite endpoint, which is death and revascularization, and the result came that the culprit or the culprit patient, they have similar FFR result to where the FFR be a symbol for defer a negative lesion, and the showing that about 8% in the primary composite happen in the complete revascularization versus 20%. So in this trial, showing us that if we use FFR to evaluate the non-culprit lesion, it's a good tool, because comparing to the other group where we didn't treat, it's showing that the result about 50% they came positive in both. So there was no huge difference. And also when we did the negative, the patient, those patients. But unfortunately, there was a study came which called a Flower MI trial. I will not talk about in detail, study in sake of time, showing the opposite, where it's showing that is not superior to angiographic guided BCI.
Hey Mo, sorry to interrupt you, but everybody has only 10 minutes and 5 minutes for questions. And to be fair to everybody else, you need to go to your last slide and wrap it up.
Okay. And the randomized control trial that we had, I summarized it in my meta-analysis I did, where it's showing staged this index procedure. It's safe and effective. We did this meta-analysis, and the last trial that came last showing that's the immediate complete revascularization or two staging. And now the guideline that we have is level 1, treat the culprit and treat non-infarct if the patient is symptomatic or has a positive stress test. In conclusion, coronary artery disease elevate mortality risk in STEMI, evolving in the last decade, leading to change in the strategy and the guide harm to reasonable and more data regard imaging and physiology to evaluate those.
All right, I think we lost you there for a second. So thanks Mo. We're going to continue in this almost same topic, right? I think you guys saw there that revascularization in shock might be slightly different, and it's evolving. So Khalid is going to present basically the next phase, which is even a more extreme patient who is in shock and a STEMI. And for Khalid, it's the same thing. So Khalid came from Toledo, also highly regarded there, came here, did a super nice job in both institutions, and also has a job, right? So you're going to Sioux City, I saw, right? So that's fantastic. It's always great to have a job right after fellowship. So I'm going to save some time. Khalid, come over here. I think your talk is ready. And then maybe if you can try to do 10 minutes so that we have some questions. Perfect.
Thank you. Good morning. Thank you for the introduction. The title of my presentation is Revascularization in STEMI, but in patients with cardiogenic shock. So cardiogenic shock is a syndrome which is characterized by sudden or acute and chronic reduction in cardiac output. It's characterized by hypotension, inadequate cardiac index, elevated end diastolic pressures, and evidence of end organ hypoperfusion. Recently, we've been using this classification to describe cardiogenic shock with patients lying on a spectrum from being less sick in stage A to extremis in stage E. Stage A are the patients who are not in shock yet, but are at risk of having shock, and E are those patients who are like crashing. So we've been using this classification more often now. The reason for this presentation is that if we look at the STEMI trials in last 2 decades, the mortality in STEMI patients continues to improve, with the earlier trials having mortality of 13%, and the most recent trials having a mortality of around 1.5% only. But the mortality in cardiogenic shock continues to be significantly worse than these other patients, and it has been persistently at around 50%, which is really bad. One of the pivotal trials in cardiogenic shock and STEMI was the shock trial. And as you can see in the slide, that the overall mortality in these patients is 60%. And despite what was the etiology of cardiogenic shock, whether it was mechanical circulatory failure, LV failure, or whatever, the mortality in each of the individual groups is more than 50%. And the mortality in STEMI is usually within the first month. And you can see these graphs. This is mortality based on different EFs. And the first month is the worst for these patients. And the lower the EF, the worse the mortality. These are the patients with the lowest EF. Pathophysiology of cardiogenic shock and STEMI can be thought to have 2 limbs. One is the systemic inflammatory response limb, which is like any other acute inflammatory response with a cytokine storm leading to a systemic hypoperfusion and compensatory vasoconstriction, leading to progressive myocardial dysfunction. And what happens in the heart is both systolic and diastolic dysfunction leading to poor cardiac output, and further ischemia, and diastolic dysfunction leading to pulmonary congestion, further hypoxemia, and further ischemia. And to get out of this death spiral, the only thing that can save these patients is appropriate and timely revascularization and other supportive measures. That's why revascularization is very important in these patients. It's also important to recognize that cardiogenic shock and STEMI, it's not a uniform etiology and can have multiple pathophysiologies, and we have to identify it earlier, whether it's due to LV failure, biventricular failure, right ventricular myocardial infarction. And sometimes, apart from history and physical exam, doing a comprehensive right heart catheterization in a timely fashion can help us understand the etiology and treat it accordingly. It's also important to exclude mechanical complications in this patient population, such as in this diagram in the labeled as A, free wall rupture, ventricular septal rupture, or papillary muscle rupture, because identifying these patients earlier, they require urgent mechanical circulatory support and may require urgent surgical treatment. Survival in cardiogenic shock has been shown to improve with revascularization and other things that we use, such as inotropes, vasopressors, mechanical circulatory support. These are useful temporizing maneuvers to help us reach the stage of revascularization for these sick patients. The major categories of mechanical circulatory support we use are balloon pump, Impella, ECMO, or tandem heart. Depends mainly on the characteristics of the patients we are treating and the institution policy or the comfort of the physicians treating these patients with different mechanical circulatory support devices. The reason for using mechanical circulatory support is, one, to maintain end organ perfusion and reduce intracardiac filling pressures, reduce LV volumes, augment coronary perfusion, allow time for recovery of stunned or hibernating myocardium, and limit infarct size. One of the first and the landmark trials that came out for cardiogenic shock in STEMI patients was the shock trial, and basically divided patients into immediate revascularization with either PCI or CABG versus initial medical stabilization. And this is survival at 6 years. And you can see that the survival in the early revascularization group is much better compared to the patients who just received medical stabilization. Although you can see that these survival numbers are still very poor, but still, even in this sick patient population, revascularization will help, and it was statistically significant. So what kind of revascularization strategy should we adapt for these patients? And like for any, this is from the recent revascularization guidelines, any patient presenting with STEMI within 12 hours, if PCI is feasible, then we do PCI. If it's not feasible, then we perform CABG. And the important thing here is that even if patients have symptom onset for more than 12 hours, cardiogenic shock is one of those conditions where revascularization is still recommended. And the level of evidence is 1 with PCI, and if it's not feasible, then with CABG. So how urgently should revascularization be performed in cardiogenic shock patients? This data comes from the FIT STEMI trial, which recruited 12,000 patients, and they found that in cardiogenic shock patients, every 10-minute treatment delay resulted in 3.31 additional deaths per 100 PCI treated patients. So every minute counts for these patients for revascularization. I already briefly touched on this, that even in patients who present after 12 hours in cardiogenic shock, the revascularization is still recommended. This is mainly based on expert consensus. There are no randomized controlled trials in this patient population for this condition. Is there a role of fibrinolysis in these patients? The brief answer is that not a big role of fibrinolysis. The immediate transfer to PCI-capable hospital is recommended in patients with shock or acute heart failure, regardless of the time delay. So even if there is an expected time delay of more than 2 hours for these patients, compared to other STEMI patients, we still recommend that the patients be transferred to PCI-capable centers because PCI significantly improves the mortality compared to fibrinolysis. So similar to what Dr. Salih was talking, that what is the role of revascularization for non-infarct-related arteries in cardiogenic shock, meaning that we treat the culprit artery, and what do we do with those other arteries that might be stenosed as well? Multivessel disease affects more than 70 to 90% of patients with cardiogenic shock. So a lot of patients have multivessel disease. So what do we do with these non-culprit arteries? The landmark trial in this field was a culprit shock trial, which showed that if you do multivessel PCI versus culprit lesion only PCI, that culprit lesion PCI was significantly better compared to multivessel PCI. The composite primary outcome, which was overall death and renal failure, was much better if you just focused on the culprit lesion PCI. And the main outcomes were driven by mortality. As you can see, the blue line is the culprit lesion PCI versus multivessel PCI, and same for renal replacement therapy. So based on this trial, the current guidelines do not recommend multivessel PCI in cardiogenic shock patients and label it as harm. And so we are not supposed to do it. So what does the future hold for this patient population, and where is this field going on? So we have some insight from the National Cardiogenic Shock Initiative. This data is limited by being non-randomized, but still better in this patient population. So they mainly came from Detroit, and this is called the Detroit Cardiogenic Shock Protocol. So what they did is, instead of performing immediate PCI, they put Impella in all the patients, which is left ventricular unloading device. So after putting the Impella in cardiogenic shock patients, they wait for around half an hour and then perform PCI after that. And this study found that the survival rate was 71% at hospital discharge in 400 patients, so significantly better compared to the historical 50% we have been stuck on in this patient population. So this has paved ways to other trials in this patient population, such as the DORT unload in STEMI, which was a pilot trial, which was not in cardiogenic shock, but it is in all anterior myocardial infarction patients. And basically, they enrolled 50 patients. And in all of these patients, they put in Impella devices, unloading the left ventricles immediately. And half of them got immediate revascularization, and half of them they waited for 30 minutes for the Impella to work and then performed revascularization. And this study did not show any significant difference between the two groups, but this is a small study. This is a pilot trial to just show us that this could be safely done. And they have a bigger trial now going on in this field, and the trial is supposed to be completed in 2030. So will give us further insight whether this might be the strategy going forward. Thank you very much.
It's always hard to keep something in 10 minutes, so good job. Maybe a couple questions, because that's always the most fun part. Anybody with a cash question here? You have a question?
Dr. Chavez has an online question. So he's got a couple comments and then a question as well. So he says, very nice review. given that most endpoints in these randomized trials are driven by repeat revascularization, one could surmise that repeat revascularization is simply another way to say staged revascularization, possibly driven by symptoms, repeat admission, CHF, or ACS. Can you comment on this view? What evidence is there for significant differences in hard endpoints, death, CHF, and MI in immediate versus staged revascularization?
I think the evidence is favoring for cardiogenic shock patients to not have immediate revascularization, but if they are like stable and doing good, then the current guidelines recommend that we do complete revascularization in patients who do not have hemodynamic abnormalities. Problem is that if you perform at the index procedure, you give them a bunch of load of dye, and then results in further heart failure and acute kidney injury. So in cardiogenic shock patients, that's why it's recommended that we just focus on the culprit artery. But for sure, for if like Mohsin presented, in patients who are hemodynamically stable, the recent trial that just came out in ACC 22 or 23, there was this trial that suggested that even at the index procedure in STEMI patients, if they are stable, we should be performing revascularization in all the arteries. Thank you.
Questions?
Can I ask a follow-up question to that? So, thank you. So in patients where you're doing the revascularization, is there a good metric how long you have to put them on mechanical circulatory support? Is there any evidence or data which supports that, you have to put these patients for X time, or what are the metrics around, okay, now that I've put my patient on mechanical circulatory support, now I can go forward with revascularization?
Yeah, I think that's a good question. And the Detroit shock protocol, the protocol that they used, and in the trial that I showed, they put the patients on Impella for half an hour before doing PCI. So they put the Impella in them and they wait for half an hour just to unload the LV, and then they perform the PCI. After they perform the PCI, then they do the right heart catheterization, and then they look at all the numbers. And if they see, oh, there's right heart failure, then they will put another device to support the right ventricle. Or if they see now the patient is doing better and everything is good, they might even remove the Impella device. Or they might see that there's persistent left ventricular failure, then they would leave the Swan Ganz catheter in place, and then see subsequently in admission of numbers improving, and then remove as per the patient is doing.
Excellent job. So this is rapid fire. Sorry that nobody gets really the full attention, but so Costas. Costas is a real disappointment because so Costas, you came from Presbyterian when you came here. You were interventional fellow there, but Rush was your cardiology fellowship. He did a very good job, and finally, we have considered a structural heart disease fellow for a job here, and he got it. All right, so I think I can say that, right? I mean, you didn't sign, but. Yeah. Okay. Here you go. You're presenting, I think, on a very important topic.
Perfect. Thank you. All right. Good morning, everyone. It's a little bit of a different topic than everyone else. So it's cerebral embolic protection during TAVRs, and it's a little bit of a hot topic these days. So we all know that TAVR has been there's been a significant increase in the use of TAVR over the last 10 years. It's now the primary form of aortic valve replacement. Overpassing surgical aortic valve replacement. Clinical strokes occurs in about 20.5% of the cases, and it's usually pre-procedural, so it's not only happening during the procedure, but as you see, it can extend all the way up to 30 days. We do know that stroke after TAVR is associated with increased in-hospital as well as 30-day mortality, and it can lead to decreased home discharge, adding an extra burden both to the hospital systems as well as to the families. The incidence of stroke has actually significantly decreased from the first generation of TAVR valves to the later ones and lower risk patients. So you see from the partner one, stroke rate, it's about 5% is where they're inoperable in high risk patients, going all the way to less than 1% in the low risk patients. When you look into the community, though, and we look at the STS and TVT and the STS ACC TVT registry, what you see is the rates have been pretty stable. They've been around 2.3%, which is consistent with what we see. And most importantly, there is no learning curve on strokes and TAVRs. There is no association between high-risk centers and lower risk for strokes. So for the first 100 cases, you might see a little higher rates, but once you cross that burden, there is like the rates maintained stable. Of note, we do know from prior studies that embolic CNS injury is very common in TAVR patients. It can happen all the way up to 93%. And these are based on diffusion weight MRI findings. They're more frequent than surgical AVR. The size of the lesions are significantly smaller. But most importantly, these do not translate into clinical strokes. So seeing an MRI with embolic phenomena after TAVR is a very common thing, but that's not a clinical stroke. And that's been shown over the trials for years. Sentinel is currently the only US approved device for cerebral embolic protection. It's placed through a 6 French radial axis. It's used a deflectable catheter. It has 2 independent filter baskets. The one is positioned in the innominate artery. The other is in the left carotid, which leads to pretty much protection of 90% of the circulation. The left vertebral artery is not protected. And on the prior trials, it actually shows that there is debris capture in more than 99% of the TAVR cases. The device got approved based on the Sentinel IDE trial that showed that it's a safe. There's no difference into the 30-day major adverse event. However, it did not show any significant difference in new lesions and volume of new lesion volumes and MRI. And the device primarily got approved because it showed that it captures debris. And we always thought that this debris is coming from the valve, which is not 100% true. So looking at the pathology of it, it actually can be anything from acute thrombus, arterial wall, foreign objects, calcification. So it's a mixture of things. And the same rates were actually shown in the Sentinel low and in the intermediate risk cohort that the company maintained. Although those results seem promising, there's actually a very low adaptation of cerebral embolic device in the US. And that's the result of the fact that there's a lot of meta-analysis, a lot of other data showing that it might not really benefit for strokes. And that all set the floor for the first randomized trial, which was the protected TAVR trial. It included 3,000 patients undergoing transfemoral TAVR, randomized 1-to-1, 1,500 were assigned in the cerebral embolic protection group. Primary endpoint was stroke within 72 hours or a discharge, whatever happened first. Secondary endpoints were disabling stroke, death, TIAs, delirium, major or minor vascular complications, as well as acute kidney injury. Most importantly, the data were, the patients were examined by a neurologist, so the stroke was a clinical diagnosis and it was not purely an imaging one. And the groups were nicely balanced. The only difference was the gender. Female sex was more common in the cerebral embolic protection group. And there is data out there that showed that female gender is actually associated with higher rates of strokes in some of the trials. So it's something to keep in mind. Most importantly, protected TAVR was a negative trial. There was no significant difference in all strokes between the 2 groups. There was an evidence, there was a hint that there might be a difference in the disabling strokes. However, the study was not powered for that. And most importantly, the number needed to treat was 125 patients. So there is definitely not enough data to support that you can actually help with disabling strokes. Looking at its safety, it was a safe device with very low all-cause mortality, low rates of access site complication, as well as acute kidney injury, which is very consistent with the data we knew from the IDE trial. The last point that it brought up a lot of discussion is that we cannot really predict who's going to have a stroke, what subgroup, which ones are the higher risk ones, and which ones should be using the device or not. So there was no difference in any of the subgroup they analyzed. There are limitations to the study. There are limitations coming from the fact that they had lower rates than expected for stroke. It was a short-term follow-up. There might be some selection bias given that the fact the device was also commercially available. So the discussion that higher risk patients might have gone placed on the commercial arm and not included into the trial. Nevertheless, that set the floor for the upcoming British Heart Foundation protected TAVR trial. It's a larger one. It's about 8,000 patients. Similar concept. It randomizes them to protection or not. And there is belief that it might be it might be stronger in looking into disabling strokes. And there's also a meta-analysis actually coming up, combining the results from this one as well as protected TAVR, looking at basically at the disabling strokes. Finally, there's a lot of upcoming devices with different mechanisms trying to actually cover all four arteries perfusing the brain. And there's a lot of excitement into actually being able to bring that rate of 2.3 to a lower level. So that's my conclusion. Pretty much TAVR is pretty common. It happens about 2.5% of the cases. It's peri-procedural. It's associated with significant morbidity and mortality. We do know that MRIs following TAVR will show embolic phenomena. That doesn't mean it's a stroke. In the majority of them, these are silent lesions. Cerebral embolic protection, it's safe. Based on the data we have so far, it does not reduce all strokes. There is a possibility it might be decreasing disabling strokes. That's remain to be seen. And there's a lot of other devices coming up in the pipeline, so should be a lot of excitement in the field.
Excellent. Any questions?
I'm assuming that the device is taken out after the procedure.
Yes. So the way the procedure is staged is like the device is placed during the procedure, the valve is getting deployed, and once the valve is deployed, we remove the filters are getting retrieved and removed, and a standard radial band is placed, which is removed based on the standard protocols as the same as PCI.
So for patients who have predisposed to stroke, have you seen any devices that are left in place over a long period of time chronically?
No, I have not. The problem is that we don't know, and that's what part of the data is, we don't know who's predisposed. We always felt that bicuspid valves, females, like certain patient population, we felt are going to be a higher risk. There's no subgroup analysis that actually shows that you predict who's higher risk for stroke.
Nice job. Is there any knowledge about cognitive testing in post-TAVR patients, given the high rate of what you're showing on the MRI?
So they are actually, so they did cognitive testing and also in all those trials with a diffusion weighted MRI, and that's why they concluded that there was no significant cognitive changes, and that's how they concluded that the lesions did not actually correlate into a clinical stroke. And that's why all the trials have shifted to having actually neurologists evaluate and make a clinical diagnosis with questionnaires and all the appropriate clinical testing than actually just doing a plain MRI.
It's a big topic. Dr. Jim. Sorry, we're really moving quite fast here.
Welcome to the group. So I'll try to be quick. I'm going to introduce the last two. We have two senior fellows for our vascular surgery fellowship here. We have Sarah, who originally is from Florida, joined us from finishing general surgery training out in California in Santa Barbara Cottage Hospital. Chris Pedersen, he is from this area, but trained down in Baylor down in Dallas, and they're both here as our second-year senior fellows. I think their topic's going to be penetrating aortic ulcers, and I think Sarah gets to go first.
Good morning. Thanks for joining us in this rapid fire grand rounds. So we're just going to discuss penetrating aortic ulcers, and we're going to talk about the background, diagnosis, and some treatment, including some new endovascular options for patients with aortic disease near the left subclavian artery. So we had an 84-year-old male who presented to our service after undergoing an aortic valve replacement and coronary artery bypass grafting and was found to have an incidental penetrating aortic ulcer. Imaging demonstrated a penetrating aortic ulcer measuring about 14 millimeters just distal to the left subclavian artery with an aortic diameter at that place around 40 millimeters. You'll see on the CT scan here that there is some mild atherosclerotic disease burden in the aorta as well. Ooh. It's on the pointer, maybe, is that why? Okay. Well, looks like the axials do not want to play for us, unfortunately. You can see up here this penetrating aortic ulcer and outpouching in the aortic wall. Here's a picture as well as still shot. So again, the measurements of the aorta, about 4 centimeters here and almost 1.5 centimeter PAU. It's backwards. Here's your axial. It's quick, so I'll let it play again. Right here. So penetrating aortic ulcers, these are focal atherosclerotic lesions of the aorta due to a disruption of the internal elastic lamina. This can also disrupt into the media, causing an intramural hematoma, or even extend into adventitia, forming a pseudoaneurysm, which is at risk for rupture. Over time, these pathologies can degenerate further into saccular aneurysms. They do often occur in areas of atherosclerotic disease of the aorta, but not in all cases, and they're most common in the descending thoracic aorta. Compared to other acute aortic syndromes, they do have a different etiology. These are not seen in areas of maximal hydraulic stress, such as the ligamentum arteriosum and the descending thoracic aorta, and often do not occur in more frequency in patients who have genetic disorders such as Marfan syndrome. And of all the acute aortic syndromes, including aortic dissections, intramural hematomas, penetrating aortic ulcers are the least common, only accounting for about 2 to 3% of these cases overall. These are often asymptomatic and incidentally found on imaging, but they can present with our patients similar to those with aortic dissections, with severe chest pain, often in hypertensive crises as well. Depending on the location of the the penetrating aortic ulcer, they can also have abdominal pain and other similar findings. CTA is the gold standard imaging modality. This allows us to better look at the aortic wall, look for the outpouching that's characteristic of the penetrating aortic ulcer. It also allows us to assess for any concomitant intramural hematoma, contrast extravasation, or pseudoaneurysm, or even rupture. It is important to distinguish penetrating aortic ulcers that are isolated and not associated with intramural hematoma because those have a different overall disease process than those that are associated with intramural hematomas who have a more guarded prognosis. Management of all of these patients should start with anti-impulse control with a goal systolic blood pressure less than 120 and a heart rate from 60 to 80. Beta blockade should be the first line agent for these patients for the anti-impulse control. In general, patients with symptomatic penetrating aortic ulcers or those associated with IMH should be repaired in urgent fashion. And patients who have asymptomatic PAUs with high-risk features, which we'll discuss on the next slide, should be considered for repair. But a patient that does not have any of these high-risk features and is asymptomatic can be clinically monitored over time. Historically, these were treated with open repair, but there's a growing evidence for endovascular repair as well. These patients are often comorbid with multiple medical problems, and you can imagine that the morbidity and mortality of open operations in this population remains quite high. Therefore, there is a lot of need for endovascular therapies. When thoracic endovascular grafts came out, this was one of a really good technology for that. And there's even newer disease for technologies that are encroaching towards the left subclavian artery. And then for high-risk imaging features, these include a maximum diameter of 13 to 20 millimeters. So that's the width from the tear in the aorta to where the actual adventitia, this would be here. And then you have you need to know, maximum diameter from 13 to 20 millimeters of the PAU, a depth of it of greater than a centimeter. If patients have been seen to have significant growth over time intervals, though this was based on the ACC and AHA guidelines, and they don't really consider what they think is significant growth. PAUs associated with saccular aneurysms are also considered high risk. And any PAU with increasing pleural effusion, as that could be concerning for pending rupture. Chris is going to take over with the other half.
All right, so when it comes to these PAUs, a lot of them are asymptomatic, as we just talked about. And a paper out of circulation for a couple of years ago from Mass General followed 280 patients over 10 years, and only 6.5% of those asymptomatic patients actually develop symptoms, radiographic progression, or rupture over 10 years. So these patients tend to not, they kind of are stable and need to be followed, but tend to not need any kind of surgical intervention. When comparing, the operative mortality for some of these procedures, as we mentioned, they tend to be pretty comorbid patients, typically older patients, and operative repair, open repair, pretty wide range here, but a 9 to 20% perioperative mortality. With the advent of TVAR devices, we're, expected to see a lower mortality, which we are seeing, and pretty good technical success rate. And in terms of just treating PAUs, it's uncommon, so we don't have a lot of data just for PAUs, but more in general aortic disease. So as I mentioned, endovascular repair is kind of the way this is moving when it's possible. TVAR is the main device that we use in any kind of descending aortic pathology. For these devices, you need a certain landing zone of healthy aorta to get a good seal, and that's about 2 centimeters. When it starts to encroach on the left subclavian artery, options include either a surgical revascularization of the left subclavian artery, or the bypass or transposition of the left subclavian artery, or this newer device, which got FDA approval in May of last year, is the Gore thoracic branch endoprosthesis. Has a built-in portal inside the device in which you can place a side branch up into the left subclavian artery. So I'll just show that real quick. So you need femoral access and left brachial artery access to establish a through and through wire and advance this device to intentionally cover the left subclavian artery, and then advance a side branch through this portal. As you can see, it takes about 2 minutes to do this whole procedure. Just kidding. So it's a promising device. It showed similar stroke rates to surgical revascularization with intentional covering of the left subclavian artery. So I think we'll start seeing this device used more and more. So back to our case. We evaluated this patient's anatomy. We used 3D reconstructions and centerline imaging, and his PAU was too close to the left subclavian artery to undergo a standard TVAR device. And being 84 years old and just having a relatively recent surgery, we thought using the TVE device may be a better option for him. So here's our initial angiogram. Oops. Anyways, not going to play, but the angiogram looked very similar to the CT scan. So you can see these are just still images of the device after it's been deployed. The side branch has been advanced through the portal, and then this is after ballooning the device. These are cool pictures, but not going to show today. All right. Well, I don't know how to make it play. Sure. Maybe. Really broke it. There we go. So you can see nominal artery, common carotid artery have common orifice there, and the left subclavian artery is well perfused and a good apposition of the stents there. So operation took about an hour and 50 minutes, took 30, 40 cc's of contrast, and the patient left the next day. And this is his 1 month follow-up CT scan, which shows the left subclavian artery portal. Let me back up and I'll show you the actual PAU. PAU FACP right there is thrombosed and totally excluded. And a 3D reconstruction of that same CT scan. All right, so in summary, PAUs are pretty uncommon, about 2 per 100,000 patients. Asymptomatic is the typical presentation. Most of these can be followed with CT scans. Medical management is, derived from literature on dissections, and patients with symptoms or high-risk features, well, symptoms should definitely be repaired, but patients with high-risk imaging features should be considered for repair. And TVAR and branch TVAR devices, we're going to offer some less invasive options for patients. Any questions?
It seems like, sometimes we have these unusual situations in the ascending aorta, and then we're trying to fix it. It may or may not work. Seems like we're not obviously avoiding that area, but do you see anything happening in that, whatever, 5, 6, 7 centimeters without encroaching on the big arteries, or is it just a no-go?
So in terms of like endovascular repair, the ascending, so there are some people doing it. That's the device, the thoracic branch device is being evaluated for zone 0 or ascending repair. It hasn't reached that kind of, safety metric yet. I think studies going for that, but the devices they have created are certainly large enough to be used for that. But then they also require still surgical revascularization of the remaining arch vessels. I think that will be coming in the next few years.
Thank you. All right.